Thanks very much. I'll call you Stephen if that's okay.
Please.
It's that.
Yeah.
It's the end of the conference. We're not quite having a drink at the bar, but I really want this to be an informal chat. And I say that as preface to the fact that I'd like to ask our speakers, as we get into some questions, I'd like to jump in at the deep end. We started the session today, or the workshop today, with Andy summarizing some themes that are coming out of the entire Diagnostic Excellence series. And one issue is that diagnosis seems to be getting increasingly democratized. It's something that society participates in, patients participate in, and also that prior efforts in diagnostic excellence have been somewhat siloed. And even today, I feel like almost sort of the gorilla in the room is, on the one hand, it's clearly obvious listening to many of the speakers about the high degree of professional sophistication that's required in the development and assessment of these tests. And yet it's also true that there's a huge amount of distrust from society about receiving the information from the so-called professionals, and they're highly motivated to be engaged in the entire process of diagnosis, sort of as almost as a self-determining act. And so I would like to put it to the four of you: are we massively overly paternalistic? Do we need to, Stephen, you said we need to have an end-to-end system. But what is the end-to-end system? Like, where's the end? And how should, if there's another disease coming, or even if we're thinking about non-communicable diseases that are in our midst right now, how should we have reframed the way we advance diagnostic excellence, such that we reconcile still the requisite professional experience with the full buy-in of the entire community we serve? So, and I open it up to whoever wants to go first. Silence.
Well, yeah, I'm probably the least qualified to give you an answer on this, but what I would say is that I have a lot of experience developing drugs, and when you start developing a drug, you start with the ultimate package insert in mind. What are you trying to do? You know, who's your target population, you know, and so on and so forth. We didn't have that kind of insight from the public or the government generally about what that package insert should look like for these diagnostic tests we were developing. It has to be, I think, the earlier in the course of developing diagnostics, you have an idea who the user community is, what the cost should be, how it's going to be manufactured, how it's going to be distributed, how will people use the information, how should people use the information. Then the more spot on you can be in the technology development, so when it comes out the factory, it's exactly what is needed. And we took a lot of educated guesses early on about that because of the immediacy of the pandemic.
Yeah, so I might add in here, Jack. I think our whole healthcare system is and remains pretty paternalistic. I mean, we're having an incredibly painful, prolonged shift to what patient-centered really means. And, you know, I think that there are a lot of countervailing forces so that, you know, there are, you know, lots of structural factors that make it harder and harder to put healthcare in the hands of the patient and help them to determine what it is that they might want and need. And that in turn is going to make it much harder for the patient with a diagnostic test or result to actually really think about all the issues about test characteristics and underlying epidemiology and Bayesian thinking and all that kind of stuff. So yeah, I think it's really paternalistic, but I think maybe to Steve's comment, and I think we heard some of this earlier, from my point of view, whenever you're going to develop a new countermeasure, a new test, diagnostic, whatever, you start with the end user in mind. And we didn't ask, and we didn't listen. We were panicked. The variety of parties thought it knew best. And I think at almost every step of the way, whether it's been in this country or other countries, are asking people and asking the public what it is that they're thinking about, what it is that they want and need, has been an afterthought instead of a forethought. And we're going to get to a much better system and much better products if it's always a forethought.
Maybe I can add, the way I look at it, as we're moving into our third year, it's hard to believe that of this awful pandemic, we're really moving away from even thinking about healthcare for most people. It's just this idea of how do you manage COVID? We're not going to eliminate it. It's going to be here, at least for now and likely for a long time. And, I think Derek, the experience on campus, maybe how it evolved. And if you look, testing is widespread on college campuses now, but not that long ago, I'm talking, year and a half, that was unthinkable. And there were only a couple places that could even do this. And there was a huge issue with equity, but, as testing became more and more available on our campus, we really had to think about the end user because, this idea of being prescriptive and saying you have to do this or you can't stay in class or you can't stay in your residence hall, but we had to make it easy. We had to make incentives. Like there's a therapy dog that comes, that everybody loves, that comes to the testing center. Right now we're giving free KN95 masks, to try to drum up interest in coming. But even as simple as like the hours of access and the place of access and the ease of access. And, I think there's something to be learned, again, some of these microcosms where you really aren't thinking so much about the way we think in healthcare, where I'm doing this test and then I'm admitting you or, treating you in the emergency department. This is more about well-being and the ability to go to school, the ability to go to work. So it's economic well-being, it's academic well-being. And so I think in some ways getting away from healthcare as the major partner here.
And I'll just add, I agree fully. It's a perfect segue. The excitement of how testing has evolved even over the last 2 years really sets the stage for what we would be able to expand to beyond COVID using tests, particularly from that health equity perspective and in terms of access and at the community levels. It opens up a whole new world when you think about it, and the fact that we went from it being heresy to it being survival will hopefully be leveraged, as we go forward.
So let's stay on that point then, because it's easy for us to really think about COVID because it's right in front of us. In the last session, though, we heard Bill talking about this window maybe on, for example, glucose monitoring. Could I ask you all to think then through this lens of listening better and being less paternalistic and knowing what the end user actually wants? Could you opine on if Omicron melted away, Deltacron ends up being nothing, and Pi never arrives, and we enter March COVID-free? How do we take this lived experience in turn to, for example, diagnosis of diabetes or of some other chronic condition or a heart disease in the community? Or how would we think, geez, let's not repeat the mistake? In other words, let's not think pandemic, but let's just for a moment play the mind game for, say, an existing endemic chronic disease.
Personally, I think, I'm sorry.
Yeah, I could just, a couple comments. I think that this seems to me like this is the public health piece, right? The public health 101 that we don't do very well in this country. There's some places that do it better than others, but these partnerships that in the communities, the barbershops, and we heard about that during the last session, and the churches, the familiar places, the places people got vaccinated. Can we use those to do other things? HIV testing, STI testing, glucose, hemoglobin A1C, lead in children especially. But can we do depression screening? Can we address food insecurity? I think it's aspirational, but it seems very possible. And to not do it, to not actually use this as an opportunity to truly move health that in a way that's meaningful, especially to vulnerable populations, just seems really would be very, very unfortunate.
Yeah. So I'll maybe go a little more granular. I totally agree with Preeti here, but I feel like one way or another, we've built a number of structures that have helped us learn to listen to some communities a little bit better. We've done a huge amount of mapping. We look at social vulnerability indices at a really granular level. We can look at community viral load. We can look at community A1C. We can look at all these things now at a really granular level. We have the tools to do those now. And I would say that we start to go to these communities. We leverage the structures that we have built to talk to communities, to listen, to ask questions, to get a sense of, to talk about the fact that they've all learned to do self-testing. They've learned to do these things, and start to talk to them about the kinds of things that would make it easier. What do they want? What would make it easier for you to think about how to take more control of your own healthcare with regard to diagnostics, with regard to how telehealth works, with regard to a number of these pieces. And I think we all have ideas about what that might be, but I think we got to listen to what people have to say. And then, to be honest, I think we need to co-design it with them and co-build it with them.
Yeah, Nicole, would that live in, I'm just question, like, where would that live? Like, would that be a state level? And again, the other Nicole, who is the state level in a state that actually has very good public health. How do you operationalize this?
Go first. Namesake.
Yes, Nicole, you answered that easy question.
So for operationalizing, what Nicole was saying is a critical piece. Is like the heart of the public health perspective. It cannot be in isolation of the community's input in terms of implementation science and how we take this diagnostic and apply it at the community level in a way that's going to inform what's needed. There are a few possibilities with that. And one is the fact that it doesn't exist at all. And that we would need to also be systematic while effective at putting together a system that can help drive that. So systematic in that we make sure we're getting the voices that we need and then are using that to actually move it forward and execute on what we would want to apply. It is one of the advantages of COVID is like, it forced you to just figure something out in order to be able to survive and move things forward. I would suspect there is always value in a federal and a map that can be used so that it is consistent in being rolled out systematically across the board. You need to make sure you have, these types of community voices, this level of diversity with that community voice, these academic partners, these governmental partners, and be able to move it forward there. And then also be clear on what you're looking to achieve from it, knowing that it's using a health equity lens. Something that stands out to me is how tests have evolved, particularly during this wave. We kind of talked about it before, but now we're actually living it. Use the tests to change behavior. If we're not going to be able to reach everyone, the thousands and thousands of positives that our system couldn't respond to, let's make sure that they get tested, understand that they are positive, and are informed on how their behavior change should occur. As we think beyond COVID, how can we use the tests in those other public health realms to also definitively drive behavior in ways that our community can definitely and needs to provide input on what's going to be most useful.
Yeah, I would add that we can divide home-based tests, at least into two categories. One is diagnosis, which is what we've been talking about all day today. The other is disease management, where there's already presumably a doctor-patient relationship and an understanding of the disease. And the question there is, if you weigh yourself every day, you're less likely to enter a hospital because of congestive heart failure than otherwise, and so forth. Clearly, the voice and the participation of the end users are critically important. It's an opportunity to mention some of the other stakeholders. One is who's paying for this. Another is what's the regulatory pathway? I can't emphasize enough how RADx benefited from working so closely with the FDA over the past year and a half. But it pointed out to me that when FDA is evaluating technologies it's never seen before, there is some learning that they need to do, and the approval may not come as quickly as you might want. And I think as we look into more innovative technologies, beyond like that tattoo that Rick showed. I mean, I can't imagine what the regulatory pathway would be for that. And so early on, I think there needs to be a consortium or, a multi-agency, multi-stakeholder group who all share the vision of a shared vision in the future, but, need to work with one another to get to that point.
So I'm just going to take the position of the dumb chair who to allow me to ask somewhat provocative questions, which I can just blame on my ignorance. So let's stay, if you like, in this space between Steve, you and Nicole. So we're in Rhode Island. My understanding is that sort of county public health offices with county health are probably relatively underfunded in Rhode Island the way they are in Pennsylvania and in most parts of the country. And we've heard many people saying basically our public health infrastructure doesn't really exist. Our ability to reach out to communities apparently didn't really exist. We didn't have a mechanism. RADx got, I think you said, $1 billion from the White House. So was there a discussion about should some portion of those funds be funding public health infrastructure to create not learning health systems, but learning public health systems? Should there be an infusion or funds flow to help fund and support adequate mechanisms for doing the qualitative and quantitative data collection and the engagement of those communities and actually put money on the ground?
Yeah, I think this was such an emergency when it got going, and you will recall something called warp speed during the previous administration. There were three aspects to it: one diagnostics, one therapeutic, and one vaccine. And NIH ran the diagnostics part. I don't know how much thought there was at that point in congressional appropriations towards these other important elements of a program: the public health perspective, education of the public, making sure that there's not a supply chain issue. I mean, there are so many details about how difficult it was, to implement RADx. And so, yes, I think what we're learning now is just because you build it, they won't come necessarily.
And I apologize for casting it the way I did, because it maybe made us look back on what we've done for COVID. And I want to redirect, forgive me, I'd like to restate that. Were there to be funding for a similar initiative going forward around, say, a new chronic disease or in preparation for a new pandemic, if you were in charge, how would you think about funds flow, and how would you fund the requisite infrastructure so that there could be a non-paternalistic, full chain of engagement learning process?
Jump in with saying I would start with being clear on what we wanted to achieve. with the particular tests, as an example, and understanding why. And so we all recognize, why we're going to focus in a disadvantaged community and engage them, and what are we looking to get by having this increased access to testing present. So with that assumption, would then want to very quickly build out the engagement with the community to shape implementation. And so in Rhode Island, where we actually don't have county health departments, so it's we are state and local in one. We have currently 15 community-led health equity zones, which are initiatives that we have created to provide that funding resourced platform for communities to organize around what their disparities are and develop data-driven goals for addressing them, and then implement those action steps and evaluate it. That infrastructure allows us to have an automatic ready-made platform for these types of required community engagement protocols. And so with the right funding, with our understanding of what we want to do with it, with leveraging our health equity zones input to get the community informed approach of what we want to do with it, we would want to be able to quickly move into piloting, learning from it, and then being able to implement.
Nicole, that sounds wonderful. I wonder, could you speak about how you are providing that funding?
Absolutely. I will put in the chat our Health Equity Zones initiative link to give more information. But what we have based the premise on is the need for grading funding, because currently our federal through to state level public health funding is in silos. And we recognized that the people receiving it on the other side don't break themselves up into silos of, asthma prevention, cancer prevention, or some other, infectious disease intervention. And none of them were getting better with the siloed funding. So we have taken the various federal funding that are focused on certain elements and have said, if you let us, and that's an effort, we braid it and give it to the community in a unified amount. We've had to build a whole infrastructure to be able to support the fact that we still have to give it back, report back to it in silos, which we're working to fix. And, anyone with congressional influence, that will make a big difference. But then be able to support those communities in actually having funding to address determinants of health instead of those clinically siloed foci instead, and then be able to say, not only do we ultimately improve the BMI and hemoglobin A1C and everything else, but they actually have fresh fruits and vegetables in their community that they never had before, and actually have access to safe streets and green policy changes so that they can actually have some physical activity opportunities that they didn't have before, and the schools are better, all of those things that we know are so critical to improving health outcomes.
So
I maybe just want to make one other comment, because I think, what Nicole has accomplished in the however long, 7 years or so that she's been in Rhode Island has really been both visionary and a model for where we need to go in this country. But she's also done that in the face of the fact that we don't have a national public health system, right? We don't, I think your question really belied it, Derek. Oh, if you got funding for X disease, right? We have to have a much more sort of integrated system that links our community and public health needs and with a national public health system and with the delivery system, and get out of the thinking in diseases per se. Now, and I think it's just really important to say that, and she's really done it and lived it, and I think as an inspiration to all of us in that regard. You know, I will just reflect a little bit from my time at the federal level that, I had responsibilities for overseeing BARDA. And if you're going to develop a new countermeasure, you had to start with the end user in mind. Whether it was clinicians who were going to use those things or patients who were going to use those things. And you ultimately developed like a target product profile for what was needed based on those needs. There's a target product profile for COVID vaccines. There's one for diagnostics in developed countries, et cetera, et cetera, et cetera. I think people were in such a rush and so panicked. Number one, they skipped that step. And number two, they didn't necessarily say, have we done this before for analogous situations, and can we apply some learning by extension? In the vaccines arena, people did all kinds of stuff in parallel. In the diagnostics arena, I think we can learn to do some of these things in parallel if we're in a rush, and one of those is really the co-development with communities.
And I think, we need to focus in on who is going to pay for this and what's their incentive. And while revamping the healthcare system to a community-based perspective, as Nicole envisioned, will undoubtedly improve health, save money in the long run. It makes total sense. It may not be attractive to an insurance company or to Medicare or to Medicaid, because they're not looking at the whole picture. They're not responsible for downstream costs, of how a BMI can cause, heart disease 20 years from now. So I don't see how this can happen unless somehow we rethink the value of healthcare and the value of, patient empowerment in their own healthcare.
I would argue that with COVID, the timeline is shortened. And I'm just thinking of right now with testing and getting people connected to monoclonals, which one of the things they do is if you get them early is they keep you out of the hospital and they prevent you from having bad outcomes. But you got to have that connection, and people don't have a PCP. There's not a central place to go. And it seems to me that that's where state Medicaid may be interested, since those may be patients that are more vulnerable in many ways, CMS. But I think employers are the other piece, because for more long-term, a lot of people stay in one place for a long time, and employers might be more willing to have that longer view on cost.
I'm trying to have us not go down the rabbit hole of ending our Friday afternoon depressed about all the problems with trying to fix US healthcare. I want to, we do have a point has been raised in the chat that's partially a question, partially a comment about whether we can leverage existing, for example, rural health networks. And certainly, I think a lot of that is also using federal money, but often, at least in Pennsylvania, it comes through Harrisburg, where we have a variety of initiatives that certainly stimulate those types of networks. And I wonder whether people could react to whether that is a good vehicle. My concern a little bit is something that Preeti alluded to, which is many people don't even have a PCP. And so I don't really know how you engage. It can be difficult for a PCP-led effort to sort of improve diagnosis for those who don't have a PCP. But I wonder, Nicole, if you've read this comment, you must have thought about this, how you leverage existing healthcare to empower public health. And of course, this is the relationship between a healthcare delivery system and a public health delivery system.
I am going to go with this, Nicole.
Yes, I'm sorry. Yes.
I appreciated the comment, and it's an important point, because certainly as systems are evolve or are expanded or built out, we want to leverage what is already in place, whether it be the mobile clinics or other approaches or the health equity zones or something else that exists in a particular jurisdiction. In terms of leveraging the healthcare system, it's a particular focus from a public health perspective. I've actually approached it in two ways. To achieve the health equity goals that we have, there are two paths to take. There's definitely been more attention paid to the path that you just mentioned, which is investing in community clinical linkages, really helping the healthcare system understand that even though they may just be focused on what's noted from a medical, diagnosis and treatment perspective, in order to get the better outcomes and to save money, which is where you can help your insurance company, our insurance company friends, and others who are looking at only reimbursing certain things to be interested. Beyond that, you can engage the community linkage to that and the determinants of health elements that are connected to it. And many places are making progress in going from how is that even possible, and I can't do anything in the medical office about someone's housing or whatever, to starting to figure out ways to do it in partnership with Medicaid and expanding reimbursement. The other major path, other than connecting, investing in clinical to community linkage, is investing directly in the community that is not always only looking from the perspective of the clinical mindset. And that's what we envision health equity zones and other place-based community-led models to really entail and allow for, knowing that it will ultimately benefit health and the clinical setting, but uses a lens that more so is reflective of the individuals living in those communities, that has health as one avenue, but also has education and housing and transportation, and overcoming violence and safety in their community as critical elements too.
So in order to keep us on a positive note, I might reflect that I'm not sure we would even had this conversation in this way several years ago. And actually throughout the day, not just in this session, we have heard about an increasing commitment towards, not just from the NIH, but from other branches of the federal government, through PCORI and others, towards more patient participatory research. We have a number of community-based initiatives. Obviously, Nicole is speaking about even doing not patient-based research, but community-based research that bypasses this notion of human beings hanging off the end of a healthcare delivery system, but human beings living in their communities. But it does seem that we're in a better place than we were. And so does it seem to you in a visionary or aspirational way that these fledgling initiatives, such as the initiatives described in Rhode Island, could be leveraged as participatory learning systems for a smarter view on diagnostic excellence in the future? And including incentives to insurers? I mean, Stephen, to your point, we have a big insurance company in UPMC, and they're absolutely thinking about the fact that there are incentives coming about initiatives in housing and in non-healthcare. I mean, is it possible? I'm hoping you say yes, but Absolutely. Is it possible to imagine that we are moving in the right direction, and that we could imagine embedding diagnostic excellence within this expanded end-to-end chain that does involve a more holistic view of public health?
Absolutely.
So, I think America's had a huge wake-up call. This is the time for us to envision and put in place the kind of system that we want and need. And I'm actually really optimistic that there are a number of pretty aligned visions out there that could get us there. But time is short, we know from all these, we'll move on to some other crisis if it's not this. And so we need to seize the moment, if not now, tell me when. And really, really get this done. But I think it's possible, it's doable, and I think it's absolutely imperative for the future of our country.
And Stephen, you brought the cold hard lens, the practicality of the financial incentives. How say you on this matter?
Yeah, we live in a capitalistic society. Companies are going to do what's in their best interest, as we heard from Marisha earlier, what's in the interest of their shareholders. We have public health imperatives. We have brilliant innovators out there with technology. The magic will happen, I think, to help finish the day on an optimistic note. What we've seen in Radix Tech, for example, is really incredible. I mean, the word unprecedented today has been used a number of times. So let's not make this the one precedent only ever for how motivated, well-intentioned, dedicated people from various disciplines and government agencies and companies working on the same page can improve the lives of people, including NIH. I think here's a wonderful example where NIH is investing a lot of money in healthcare and in the care of people and health of people. And I see that and I think Radix was viewed generally as a successful experiment that can perhaps be emulated or, applied towards other major health issues, whether they're in cancer, heart disease, and so forth. And, bring in many of the concepts we've talked about today, but NIH alone can't do it. So we really need to understand the minimum, necessary infrastructure to achieve what we're talking about today, and perhaps starting with chronic disease management, because I think that's an easier entry point for FDA to get involved with than, diagnosis per se, of, a new diagnosis per se. But however, the strategy, I think what we've learned from each other all day and in our work this past couple of years is that we had no idea what's possible before we started all working in this area. And now we have an idea what's possible. How do we, build on that?
Perfect. And Preeti, love to hear your thoughts. And one of the things, I know you care a lot about messaging, digital media. It's another thing we haven't got to too much in this hour, but it came up a lot during the day. We heard about us being in the middle of an infodemic, and it was cast a little bit about the problem of misinformation. But I wonder if you could just reflect on, isn't it actually great that we've democratized all this information? I think Daniel Yang had mentioned earlier about these super informed patients of his that are asking about pretest probabilities. To what extent do you envision that are we actually looking at, used correctly, could this be a boost in health literacy? Instead of focusing on the misinformation, is there something to be harnessed positively from this chapter of the information age?
Derek, I want to also end on a positive note, and I think for some people this has been a time of transformation for them personally, like really taking a real interest in their health, and hopefully that'll continue for some. But I also worry that the group that is disengaged is even more disengaged. And how do you there's not one way, and as I was hearing about some of the work Nicole is leading in Rhode Island, it almost feels like a dozen demonstration projects. And you mentioned some of the networks around rural health, and some of the large states, including the one you live in, the one I live in, like there's Detroit is very different than the Upper Peninsula in Michigan, and the solutions and the approaches have to be different. And I think it's the same around communication. But trusted messengers are really important, and that's come up a lot today. I think when we were hearing about sort of indigenous individuals, and like when the messenger had that background, that was really, really important. that may not be as important in every community, but I think thinking about it like locally, the more we can do, and I think there's been a lot learned in this space. And again, I get back, I can't help but get back to that, who is the healthcare provider in your life? And, one group we haven't talked about is pharmacists. And pharmacists have been amazing in before the pandemic, but when you think about all the vaccinations that have happened, and right now, that is a path to get like antivirals, for example. So, I think that thinking differently about the communications, I think nurses, pharmacists are frankly much more trusted than physicians for many people. But I do think you're right. There's a group of people, including maybe some of my family members who are not in healthcare, but they're much more engaged. I mean, they're talking about antibodies and immunology, but is that going to translate into better health? I'm not sure.
Okay, so we've got about 9 more minutes to go. And one of the things that I was asked to think about in this session was things that we hadn't covered. So I would like to push you on one final topic, which is getting back to causal inference and knowing whether something works. If we're really thinking that ultimately diagnostic excellence is about raising health levels in communities, and really means that this end-to-end model that Stephen talked about has to include an implementation science. And unless we're going to revert to before and after designs, presumably we're still looking for some sort of strong causal inference. It's not necessarily a patient-level phase 3 randomized trial of a strategy that does or does not use a diagnostic test, but should we be thinking about greater use of large-scale randomized evaluations of local policy initiatives or we've seen a couple of Nobel Prizes in economics in the last 2 or 3 years about the importance of randomized trials for testing economic policies with Esther Duflo and a couple of years ago, and then even this year. Should we be envisioning from a science standpoint that we want to see high-grade science conducted on these different strategies for trying to penetrate diagnostic excellence into communities? We don't do many. We had the Rand insurance experiment a long time ago, but is that something that should be part of this future?
I would think so. I mean, otherwise, how will we know best practices when we see it? I just put a link in the chat to an NIBIB program, Derek, that I think is looking at what you've just described. It's quite a large effort. It's worth looking at what they plan and what they've been doing. But I guess my concern about diagnostic tests is that the process of diagnosis can end when somebody does their, lateral flow test and is positive. Should that be the end, or should there be some support made available to the individual who may not understand, what a false positive is? Or, as doctors, we hardly ever take a test result alone as the basis for making a diagnosis. It's part of the picture, right? It's part of, there's signs, symptoms, probabilities, and so on and so forth. So I think if we move diagnostic testing and chronic disease monitoring closer to the patient, which I'm all in favor of, we have to think through what supports should there be for those individuals. Should it be, you mentioned pharmacists, somebody mentioned pharmacists, Preeti, et cetera. It can't, it's perhaps necessary, but not sufficient in the diagnostic process.
Yeah, and I think I want to reassure you that that's definitely been a strong theme in this entire series. Diagnosis, it's not a noun and it's not a test. It's an active process that can be a whole suite of tools around, and it's part of a process to fulfill optimal health in a community is the notion.
I think one of the problems we've had is that doctors may not always know enough about what to make of test results, so that when they're contacted by patients, it's, they feel a little bit disconnected. And perhaps, I don't know whose responsibility that is or was, but, there needs to be a major educational campaign as well, for healthcare providers, pharmacists, other people that are interacting with civilians that are doing, home-based tests.
Derek, one last 30-second word. In the HIV world, home diagnosis and linkage to care. I mean, those studies have been done in a very robust fashion, mostly outside of the U.S. And again, people didn't think it was possible to do the diagnosis and treatment in like sub-Saharan Africa, for example, and other parts of the world. And I think it's transformed the way that care is delivered. And there are robust data to show that certain ways to test do connect people and change outcomes. So I don't know if COVID has the same, with a 3-day incubation period and a lot of people not needing treatment, but let's think beyond that.
Perfect. Nicole A or Nicole L?
Much else to say at this point. I think we've covered a lot of ground. I think there's a huge amount of opportunity. I actually think it's possible to line up a lot of different incentives. Ranging both pull and push incentives and things like graded funding to get things done. And I'm eager to get on with it.
And Nicole A?
I love and want to echo Nicole's earlier comment about ensuring, whichever path we go, that we include that community voice as an equal partner in informing it, because it is a whole new world. It's a real opportunity to build out a system. The system is only going to be as successful as we want it to be if we put into it what we need to get it out on the other end. And that is that community voice to help directly inform how we want to use this most effectively.
Perfect. Well, I think that's a good stopping point. I've enjoyed listening to you all help bring together these sort of competing themes of the emphasis on community versus that sort of dwelling on the very professional technologic expertise necessary for diagnostic challenges. And you've really done a wonderful job of painting a path for how technologic expertise could be really thought about as being evaluated as whether it's actually of value for improving community health. Not that there aren't challenges you haven't identified, but I thank you all for addressing sort of the whole scope. And so I think with that, we should wrap this session and we should move to the final wrap up from my co-chair, Dr. Byman. And so I just want to thank you all very much for your comments.